Welcome everyone to this comprehensive overview of Indinavir stones, a specific type of kidney stone associated with the antiretroviral medication Indinavir, primarily used in the treatment of HIV. In this video, we will delve into the mechanisms, symptoms, diagnosis, treatment, and prevention strategies for this condition. Understanding Indinavir stones is crucial for both healthcare professionals and individuals living with HIV who are taking this medication. The primary cause of Indinavir stones is the Indinavir medication itself. Indinavir, like many medications, is metabolized by the body. A portion of the unmetabolized Indinavir is excreted in the urine. However, Indinavir has low solubility in urine, particularly at higher concentrations and within a specific pH range. This low solubility leads to the drug precipitating out of the solution and forming crystals, which can then aggregate and grow into larger stones within the kidneys and urinary tract. The risk is exacerbated by dehydration, high doses of Indinavir, and alkaline urine pH. The pathophysiology of Indinavir stone formation is relatively straightforward. After ingestion, Indinavir is absorbed and circulated in the bloodstream. The kidneys filter the blood and excrete the drug, along with other waste products, into the urine. Because Indinavir is poorly soluble, especially in certain conditions, it crystallizes. These crystals can then act as a nidus, or a starting point for further crystal deposition. Over time, more and more Indinavir and potentially other urinary salts, like calcium oxalate, bind to these initial crystals, causing them to grow into larger stones. These stones can then obstruct the flow of urine, leading to pain, inflammation, and potential kidney damage. The epidemiology of Indinavir stones is closely tied to the use of Indinavir in HIV treatment. In the early years of its use, Indinavir stones were a more frequent complication. However, with the advent of newer antiretroviral therapies and changes in treatment guidelines, the prevalence has decreased. Still, patients on Indinavir, particularly those on higher doses or with predisposing factors like dehydration, remain at risk. The incidence varies depending on the specific population studied, adherence to medication regimens, and fluid intake habits. The signs and symptoms of Indinavir stones are similar to those of other kidney stones. The most common symptom is renal colic, characterized by severe, sharp pain in the flank or lower back. This pain often radiates to the groin and is usually intermittent, occurring in waves. Other symptoms may include nausea, vomiting, hematuria or blood in the urine, and dysuria or painful urination. If the stone obstructs the urinary tract and causes infection, fever and chills may also be present. It's important to note that some individuals may have silent stones, meaning they experience no symptoms until a complication arises. Diagnosis of Indinavir stones typically involves a combination of imaging techniques and urine analysis. A non-contrast CT scan is often the preferred imaging modality, as it can readily visualize even small Indinavir stones. Ultrasound can also be used, though it's less sensitive. Urine analysis can detect hematuria and may reveal Indinavir crystals, although the absence of crystals doesn't rule out the diagnosis. A thorough medical history, including medication use, is essential for identifying Indinavir as the likely cause of the stones. While kidney stones in general have various classifications based on their composition, Indinavir stones are specifically categorized by their primary component Indinavir. Mixed stones, containing both Indinavir and other minerals like calcium oxalate, can also occur. The classification is primarily based on the stone's composition as determined through stone analysis after it is passed or removed. Treatment and management of Indinavir stones depend on the size, location, and symptoms. Small stones may pass spontaneously with conservative management, including pain medication and increased fluid intake. Alpha blockers, such as tamsulosin, can help relax the ureter and facilitate stone passage. Larger stones may require more invasive interventions, such as extracorporeal shock wave lithotripsy (ESQL) or arthroscopy with laser lithotripsy, or percutaneous nephrolithotomy (SPCNL). Alkalinizing the urine with medications like potassium citrate can sometimes help dissolve Indinavir stones, especially smaller ones. In some cases, discontinuation or modification of the Indinavir regimen may be considered in consultation with an infectious disease specialist. Prevention of Indinavir stones focuses on minimizing the concentration of Indinavir in the urine and promoting its solubility. This includes maintaining adequate hydration by drinking plenty of fluids throughout the day, typically aiming for a urine output of at least 2 liters daily. Regular monitoring of urine pH is also recommended, and alkalinizing agents may be prescribed to keep the urine pH within a favorable range. Patients should also adhere strictly to their prescribed Indinavir dosage and discuss any concerns about side effects with their healthcare provider. The prognosis for individuals with Indinavir stones is generally good, particularly with prompt diagnosis and appropriate management. Most stones can be successfully treated or passed spontaneously. However, recurrent stone formation is possible, emphasizing the importance of preventative measures. Recent research has focused on developing more soluble formulations of Indinavir or alternative antiretroviral medications that are less likely to cause stone formation. Ongoing studies are also exploring the potential of novel alkalinizing agents and other strategies to further reduce the risk of Indinavir stone formation. This concludes our overview of Indinavir stones. We hope this information has been helpful.